What's up, you guys? It's your boy Miguel giving you your daily dose of radiation. In today's video, we are covering how many morning ports do you do as a night shift tech. So to give you context, I work at a trauma 3 ER. I'm the graveyard shift. We start at 8 p.m. and exit at 8 a.m. That is our hours, 12, 7 on, 7 off. So the infamous morning portables, depending on if you have inpatients, if you have people going into surgery, there's many variables that can cause someone to to increase the amount of people that will be on your morning portable list, or why a doctor would order morning portables. Some of the most common ones that are the staple is, does someone have a chest tube? If someone has a chest tube, at least at our hospital, you know for a fact the day they insert it, every other day, like they'll be monitoring it, and the day they remove it, you will have to do a chest x-ray on this person. Already, guaranteed, always. The next one, if the patient came out of post-op for any kind of heart surgery, for sure gonna be having post-cabbage, post-cardiac, post-whatever they have going on, for sure gonna have chest x-ray. If they were intubated, they're gonna have one. Especially if like the patient's not breathing well, especially if because like certain floors, like the ICU and then the surgical ICU, those two are more notorious to have them because those are like the most critical patients, both from just critical in standpoint, and then the other one's post surgery. Because usually what happens is they start off, if they come in from the emergency room and they're like really bad and they had to rush them out to surgery, you may shoot them in the emergency room, and then when they get out of surgery, they may get something in surgery by the surgical techs, surgical x-ray techs, and then when they come out of surgery, the SICU, usually they order another chest x-ray depending on what they have going on. And then if they're really intense, usually they'll get shipped out to either the heart floor if they have any heart stuff going on, and you'll probably can keep up shooting them there. Or if they're really, really bad and have a lot of stuff going on, they'll go to ICU. And then like sometimes you'll like follow the patient from like the very beginning as they enter the hospital, and you can see how like the system, or how like your patient goes, as like it goes from like critical, and like they'll move them all over the hospital, and you'll kind of like see how like as slowly they get better, which is pretty cool. It's nice to see that people actually make it out of the hospital. But like, yeah, you'll follow the same person from different places. Another one that will happen is sometimes patients will have like, they order x-rays on their feet, like the post-surgery, like post-op, for like if they get like, if they have diabetics on their feet and they have to like chop off some of their toes, or like post-surgery sometimes you get some of those sometimes. KUBs also come into play. It's like 90% of it is chest x-ray, but you do have KUBs intertwined in morning portables. If the patient got a small bowel done, you will for sure gonna have one, because like they'll shoot KUBs all day until it finished, till the rad says it's done, and then the morning of they'll throw in another one per our rad, the request one, just to monitor and make sure they're okay. So that's another reason why you would do a KUB. And the other ones are just like if the patient complains of stomach pain, or if they've been vomiting a lot, sometimes you'll end up doing KUBs for those. And then probably intertwine all those. It's not like really morning portables, but it just gets thrown in there. It's like a lot of the NG tubes, OG tubes, placements. Those, depending on if they need them stat or not, they may get intertwined into your morning portable list, because like you'll be on the floor and like the nurses will sometimes order. Those aren't morning portables, but they usually, you kind of do them on your run to try to be the most efficient as possible. What else? But as far as the actual number, at ours, it all depends what kind of season we're in. I know for a fact, if we're going into peak season, peak like flu, COVID, like all the winter season, we can range from like 30, I think, with add-ons, because sometimes the residents or doctors forget to, like, their order set will cancel, will finish, and they'll forget to put another one. You may be looking at like 30 to 40 at like max. So usually we'll split it up, because there's two sides of the hospital, and then we'll kind of like go shoot them in individually. And I mean, the lowest we've seen, I've witnessed, was probably like 10. It's like on a good day, only 10. Which, that one always is an interesting position to play, because it, depending on how that goes, it will like affect your overall work experience for that day. And depending on what you have in your emergency room will kind of determine how you play, or even your ER alone will kind of have you thinking of the game plan, because sometimes you have to kind of strategize, because like if you know that the ER is super full, and there's certain doctors that are more notorious for ordering a bunch of stuff, because some doctors will order it, and then whenever you get it done via 30 minutes, via an hour-ish, they kind of understand. Ours doctors are pretty good to understanding that at a certain time period we go to do the other x-rays, and then we'll come back. They're pretty good. Unless it's like a trauma, then we may get dragged down from the floor. Certain variables that we can't really control. But they're pretty good. Certain doctors, you already know that they're more notorious for any little thing. They'll drag you down and bring you back. So sometimes you have to kind of plan. But yeah, it's been your boy Miguel. See you on the next one.